Hi guys, hello family, hello friends. This is Dr. T and welcome to Clinical Medicine with Dr. T. So we have been covering spinal anesthesia. So today we are going to be starting with the complications. Remember we did mention complications of spinal anesthesia. So the first complication of spinal anesthesia that we're going to be talking about is hypotension. Spinal anesthesia induced hypotension. Very common, guys. It's a very common complication, and there are some articles that it's common, like it's between 16 to 38%, and then there's an article that says it's about 60%. There's one that says about 68%. That's how common it is. But according to my own observation, I think it's common up to about 80%. I think even 90, guys. So common. It's also common. There are very few patients that I have seen that would actually go in to theater, have a spinal, and then not need vasopressors. There are very few patients. So it's very common. I mean, when you talk about the complications of spinal anesthesia, always mention hypotension. It's very, 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 very common. Since it's so common, so it's worth it's worthwhile that we talk about it and just discuss it and yeah. So how do we define hypotension? There are different definitions out there. Many people say it's a blood pressure that is less than 90% systolic. That's why many people, you find that when the blood pressure is below 90, they start giving vasopressors. But the question is, what if this patient is a hypotensive patient? Because we've got different blood pressures. So then for that class of people, group of people or population, the issue, the definition of 20% works better. So the blood pressure should not drop by more than 20% systolic. It must not drop more than 20%, meaning more than 20% of the baseline. So which means when a patient comes in, they should have a blood pressure before the spinal, and then we use that blood pressure as a baseline. Then we must not allow our blood pressure to drop more than 20% of that baseline. Yeah, there are other definitions as well. Then there are people who just get worried when the blood pressure is below 100. When the systolic starts dropping below 100, they just start to get worried right there. Okay, so now, why do we get this complication? The reason why we get this complication is because local anesthetics, and so these local anesthetics that are given during spinal anesthesia, they block the preganglionic they block the preganglionic sympathetic fibers. And once they block those preganglionic sympathetic fibers, they cause vasodilation. we know that once you have vasodilation, remember our formula. BP is equal to cardiac output multiplied by peripheral resistance. So peripheral resistance is all about increasing or decreasing vascular tone. So if you are vasodilating, it means that you have decreased vascular tone. So once you have a decreased vascular tone, you decrease peripheral resistance, and because you have decreased peripheral resistance, you decrease your blood pressure as well. So that's how you get a decreased blood pressure, and we know that a decreased blood pressure is hypotension. So that's how we get the hypotension. So vascular tone plays a very important role when it comes to the blood pressure. So once you get vasodilation, the first thing that you get, once you get vasodilation, you get a decreased peripheral resistance. That's number one. Number two, once you get vasodilation, so you get a decreased PR there. Then another thing, which is the major reason, is once you get vasodilation, you get a decreased venous return. Venous return. Once you get a decreased venous return, you get a decreased preload. Once you get a decreased preload, you get a decreased stroke volume, and we know that a cardiac output is made up of stroke volume multiplied by the heart rate. So can you see? So now once you decrease your stroke volume, you decrease, and we know that cardiac output is a product of stroke volume multiplied by heart rate, or is a product of stroke volume and the heart rate. So once you decrease stroke volume because you have decreased your preload, it means now you're going to decrease your cardiac output and then decrease your blood pressure. So that's how you get the hypotension from spinal anesthesia. Those are the two ways. I'm sure there are others as well, but this one is the most common one that is explained. Okay. So I just had to clear this so that we can have enough space. So we have spoken about the fact that the hypotension that you get with the spinal is because you have blocked your sympathetic, your preganglionic ganglionic sympathetic fibers, and because of that you get vasodilation. That we understand, dilation. So this is why you get hypotension with spinal anesthesia. So since you know that hypotension is an expected complication with the spinal, so it means when you take a patient in for spinal anesthesia, you must do things, or you must put measures into place that will minimize the hypotension. One of those, the first one is preload the patient. Preload the patient, meaning giving a patient fluids before the spinal. There are different kind of debates and ideas about the preload. There are people who say that crystalloids are not so useful when you preload a patient with them, because crystalloids, they are redistributed in all the compartments. Remember, we've got the intravascular compartment, and then we've got the intracellular, and then we've got the interstitial compartment. Those are the three compartments that we have. Those are the three fluid compartments that we have. So what they are saying is that when you are preloading a patient, you want to increase the intravascular volume. You want to increase the intravascular volume. That's what you want. But now they say if you give a patient crystalloids, you will give this water here, but this same water will start going out, getting into the interstitial fluid and also into the into the intracellular compartment. So, but you don't want the fluid to be here, you want the fluid to be here. So it's useless to give a crystalloid. So now people start to propose the issue of colloids. That why don't we preload with colloids? But now the problem, colloids are very expensive to start with. Very expensive. And we use colloids when sorry about that, I don't know why I'm saying colloids. So we use colloids when we are doing like sort of like an aggressive resuscitation of a patient. They are expensive, and also the advantage is that they tend to stay for a longer time in the intravascular space. But the issue is that they are expensive, and there are people that develop anaphylaxis from them. Because remember, some of them have got starch, some of them have got protein, and that and that and that, that. So imagine now you are preloading a patient who's going for fetal distress. You are giving them fluids, and then while you are watching that, they develop anaphylaxis. And that would be a nightmare. So now people are like, let's not. There are people who prefer giving those, but that's just the problem with them. And then now people are like, okay, why don't we do what is called Coloading? So Coloading is giving a crystalloid. Remember what crystalloids are, guys? Crystalloids are fluids like normal saline, the most common normal saline, then there's lactate, and there are so many of them. These are the most common ones. Maybe we'll do fluids and then talk about those. So when you are co-loading, you give crystalloids plus a vasopressor. And that vasopressor, phenylephrine is the most preferred one. That's co-loading. So giving a patient, preloading a patient is very important, because there are patients that, because they are told that they're gonna go to theater, they are not given food, so they are fasted. And the fasting, there are very few people that follow fasting the way the protocol states, because if you're gonna have nil per os for 6 hours, 8 hours, definitely by the time you go to theater you are behind with fluids, you are dehydrated. Because remember, your maintenance fluid you're not given, but you keep losing fluid by sweat, by urination, all those things, and all of that. So you will be behind with fluids. So because you're already behind with fluids, and then now you get a spinal. So when you take a patient to theater, you want to take a patient to theater who's hydrated, well hydrated. Some people, they really maximize this issue of preloading a patient, because they know, because the protocol of fasting is not well. It's not nice for someone to be fasted for 6, 7, 8 hours. And the fasting that people always tell patients to do is the one that you must not take anything, like not even clear fluids. But the protocol says that you can take clear fluids as long as it's not 2 hours is gonna pass before you go to theater, and you can take things like what's this, unclear fluids, if I may say, like your juice, your apple juice, you can take those. I think if I'm not mistaken, 4 hours before the operation, and then you're allowed to take food, but 6 hours must pass before you can go for your operation. So which means that a patient should at least have water, as long as you know that they won't go to theater in the next 2 hours, and then you can avoid this issue of a patient going to theater and then they are dehydrated. Anyway, so yeah, so these are the so I must put it here. Let's follow the fasting protocol properly. Follow the fasting protocol. Imagine it's hot, like hot. It's one of those hot days, and then we're not taking anything by mouth, and you are sweating, you are in the ward, you are sweating, you have not eaten, have not had anything for the past 5 hours. I mean, by the time you go to the theater, you're gonna be dehydrated, you're gonna be behind with fluids, you will likely be hypotensive, but just not symptomatic. So these are the things: follow protocol, and the fasting protocol, preload the patient. Now, the preloading that usually happens is, in some places the patient is going to receive crystalloids, maybe just 1 liter of the crystalloid before they go to theater, or some will say, okay, let's run 500 mils before the patient goes to theater, things like that. But what normally happens now, the co-loading, there is no one who gives the patient crystalloids and vasopressors where I'm working before a spinal is in. Yes, we do run the fluids before the spinal is in, and then we wait for the blood pressure to drop before we can give the vasopressors. But the vasopressors are always ready, right? They're always ready. So, yes, to avoid the hypotension, we said preloading the patient, co-loading, follow the fasting protocol properly, and then in theater you are gonna give the fluids in theater now, plus the vasopressors as needed, right? One other thing that is also crucial in theater is the position of the patient. We need to avoid what they call aortocaval compression. Aortocaval compression, you know, it's when the mom is lying on their back, so they're supine, and then the gravituterus presses on the inferior vena cava, and that acts as an obstructive lesion, so it decreases the venous return, and you end up having a low cardiac output and a low blood pressure. So that's why you'll find that patients are going to be tilted more to the left side. They're going to use the bed, and even sometimes they even put some stuff, maybe a pillow or some vacuolators under the buttocks of the patient, or just just above the buttocks. So those are the ways to prevent to minimize hypotension. Now let's talk about the drugs, the vasopressors. Very important, very important. So if a question comes and say, how do you prevent or how do you minimize hypotension, say due to a spinal, you can start mentioning the preloading story, talk about the co-loading, and then following the fasting protocol properly, fluids and vasopressors, and aortocaval compression.